everyone. Welcome to the Thyroid Stimulating Podcast. This podcast was created in partnership with the American Thyroid Association. Our goal is to discuss up-to-date diagnosis and management of a wide array of thyroid diseases. Today, we'll discuss hypothyroidism and its treatment. Hypothyroidism is a common condition present in almost 5% of the population, so it's likely that most doctors would have treated someone with hypothyroidism at some point in their medical career. Today, I have the pleasure of talking with Dr. Antonio Bianco about the treatment of hypothyroidism. Dr. Bianco is an internationally recognized expert in the field of thyroidology and a past president of the American Thyroid Association. His clinical practice focuses on the treatment of hypothyroidism. He has authored over 240 peer-reviewed journal articles. He also recently published the book, Rethinking Hypothyroidism: Why Treatment Must Change and What Patients Can Do, which we'll talk about today on our show. Dr. Bianco joins us from the University of Chicago, where he's currently a professor of medicine. Thank you so much for joining me today, Dr. Bianco. It's a great honor to have you on the show.
Thank you for having me.
I wanted to start off by asking you about your journey in medicine. What inspired you to become a physician scientist, and how did you enter the field of thyroidology?
Well, I always wanted to be a scientist since my early childhood. I have an older brother, he's a doctor, and we used to play scientists at home. And then actually I went to medical school just because my brother thought I would be a better scientist if I went to medical school as opposed to having a PhD in biology or in some basic sciences area. But then I fell in love with patients and with the clinical practice. But since early in medical school, I started working in the Department of Physiology. And my first mentor, he happened that he was working with the thyroid gland. So back in 1978, I had the pleasure of working with Dr. Douglas here in Sao Paulo, and we started in the thyroid journey.
Well, thank you for sharing that. I also wanted to congratulate you on your recent book, which has received wonderful reviews from physicians and patients alike, and I've personally had the opportunity to read it as well. In your book, you discussed how hypothyroidism was initially treated with animal extract containing T4 and T3 combination, and the medical community in general was pretty rapidly changed to the practice of treating with levothyroxine, which is T4 treatment only. Can you comment a little bit on the background about how we got where we are today and how this change has impacted patients with hypothyroidism?
Sure. So as you know, since the understanding that hypothyroidism existed as a clinical syndrome, very rapidly after that, we started giving thyroid extracts, animal thyroid for patients. And that happened, the better part of the 20th century, patients were treated with desiccated thyroid extract. Until around 1970, that people understood at that time the seminal work by Dr. Braverman, Dr. Ingber, Dr. Sterling, showing that T4 got converted to T3 inside our bodies. We didn't know that. The interesting thing is that back in the 50s, there was an idea that T4 could be converted to T3. However, that idea was abandoned. There was a publication, then the paper was retracted, and it was rediscovered by Dr. Braverman in the 70s. Now, people did not like desiccated thyroid extract very much at that point because its potency was inconsistent. Different brands had different potence, and even within the same brand, different batches could have. And that is because the animal, our thyroid, the amount of T4 and T3 fluctuates with the season of the year, fluctuates with the amount of iodine we eat. So understandably, they were taking thyroids from different animals, different places in the country, and making different potency of thyroid extract. So doctors did not like that much, but it was effectively good, so they had experience with using it. Now, in 1970, the discovery that T4 got converted to T3, the doctor said, well, wait a minute, we don't actually have to use this desiccated thyroid extract anymore. We just give T4, which has a very long half-life, will provide a steady level of T3 in the circulation, and we know exactly how much we're giving because this is synthetic micrograms, and it's so greatly advantageous over the treatment with desiccated thyroid extract. During the 70s, it took about 10 years. People completely forgot about desiccated thyroid extract. When I was in medical school, I was learning about these things. What? Desiccated thyroid extract? What's that? Pig's thyroid? I mean, you could even, we couldn't conceive the idea that someone could treat a patient with hypothyroidism with desiccated thyroid extract. So I never learned what desiccated thyroid extract was in medical school or during my clinical training. We were just told, use levothyroxine because it's great. And you know what? It is great. I mean, resolves the problem of most patients with hypothyroidism. But during that time, there was a noise brewing in the background. Some patients that were switched from desiccated thyroid extract to levothyroxine, they said, wait a minute, I don't feel that great. I want to go back to my pig's thyroid. And some doctors said, fine, just do it. Some doctors did not take that. No, you have to be on levothyroxine. So this noise was brewing in the background. Patients were complaining about impaired cognition. You know what? I have a hard time managing my body weight. But during these 5 decades, this noise became louder and louder. And you can imagine with social media, all these patients got together, got absolutely a huge megaphone, and their complaint was heard much louder. So today, we can talk about a little bit more. I don't want to extend too much this answer, but the situation is that we have this natural product that has resolved the potency issue because now the USP has developed a new method for standardization of desiccated thyroid extract. And so the potency issue it's no longer. The issue is maybe it contains a little bit too much T3, and the patients that take desiccated thyroid extract may complain of palpitation and tachycardia. But right now, it's the vast majority of patients are treated with levothyroxine, but a staggering 1.5 million patients in this country with hypothyroidism are treated with this desiccated thyroid extract. In the far third place, we have synthetic combination of levothyroxine and liothyronine. About maybe 300, 400,000 patients are using that. So that's the situation we have today.
So back when levothyroxine came out, currently, like these days, you would need either a non-inferiority or even a superiority trial to bring a new medication to the market. Was there any sort of comparison of levothyroxine when it came out?
No, the FDA never asked for one because remember, levothyroxine was isolated in 1914 by Dr. Kendall before the FDA even existed. So Dr. Kendall, I think he had a patent, and they had an agreement, a licensing agreement with the Squibb laboratories at that time. So Squibb was already selling levothyroxine to treat hypothyroid patients in 1916, 17, even before the FDA. So when the FDA was created, levothyroxine was grandfathered in. Now, in the 50s, a British pharmaceutical company developed the synthetic method to make synthetic levothyroxine, no longer extracted from pigs. And that was another patent. And again, the FDA accepted because they already had grandfathered the natural product, the levothyroxine extracted from pigs. So the FDA never asked for a safety testing or effectiveness of levothyroxine. And today, the normal thing would be, okay, we have a standard of care, which is desiccated thyroid extract back then. You have a new product, okay, let's do a clinical, randomized clinical trial, blinded, and let's see which one is better, or there's effectiveness, safety, but that was never asked.
Do you think anybody would do that in the future?
Yes, they are. because of desiccated thyroid extract. So this is a very popular product. As I told you, 1.5 million people take it. So this is not fully approved by the FDA. The FDA, again, grandfathered in desiccated thyroid extract. They let pharmaceutical companies sell it, make it and sell it, but it's not fully approved by the FDA. So now the FDA is telling these companies, listen, we want to resolve this situation. Either you come with as a new product and demonstrate that this is effective and is safe, or eventually we'll need to not let you sell this anymore. And as a result of that request by the FDA, now the companies that make desiccated thyroid extract are running against the clock in these randomized clinical trials to compare with levothyroxine, because levothyroxine is the standard of care, and they want to show non-inferiority with levothyroxine. So we have already, I believe, one trial was done. The results were published last year in the American Thyroid Association, a large multi-center trial, and we have another multi-center trial that is starting now from a different company.
Yeah, so I know you briefly mentioned some of the side effects of desiccated thyroid hormone, but why do you think the medical community in general is so hesitant to recommend either combination therapy or desiccated thyroid hormone? What are the main reservations that people seem to have, physicians seem to have?
Well, the main reservations that there are two. Number one is the inconsistent potency. And I think that that's really a historical reservation that should not be discussed anymore because it's no longer the problem. The second thing is peaks of T3. You know, in desiccated thyroid extract, we have 4:1, 4 molecules of levothyroxine, 1 triiodothyronine. And our thyroid contains a different ratio. It's like 14:1. So there's an idea that perhaps the desiccated thyroid extract could give a little bit too much T3. And there, you know, if a patient takes, let's say, 100 milligrams of desiccated thyroid extract, T3 levels will increase. You can measure it 3 hours later. There will be a peak of T3. The experts think that we don't have sufficient data on safety for these peaks of T3. What happens if a patient takes desiccated thyroid extract for life and these peaks of T3, could that be a problem with the heart, with the bone? Now, maybe this is a historical concern again. Today, we know better. I can tell you that there were 20 randomized clinical trials comparing now synthetic combination therapy with levothyroxine, and the effectiveness was identical and safety were identical. I mean, there were no more adverse reactions in the combination therapy as opposed to levothyroxine, number one. Number two, there were 2 clinical trials using desiccated thyroid extract, and they did not find more adverse reactions as compared with levothyroxine. And number 3, there was this commercially sponsored multi-center clinical trial with DTE published in the ATA meeting last year, showing again there were no more adverse reactions with DTE. So the bottom line is, yes, we can treat someone with levothyroxine with combination therapy, either synthetic or DTE, normalize TSH without having more adverse reactions. The problem is many doctors, when they use T3, either with synthetic combination or with DTE, they give more than actually you need to treat hypothyroidism. Because they're ignoring, and this is something wrong, I think, they're ignoring the TSH. So using combination therapy in many settings has become synonymous to suppressive therapy. And in that case, of course, if you're suppressing your TSH, you're taking T3, you're going to have side effects. You're going to have palpitation. But if you're monitoring TSH, you know, the studies have shown that we don't have more adverse reactions.
So with that, since the education is actually changing, or our knowledge of T3 and the combination therapy, do you have any advice for like fellows or fellow thyroidologists who would want to use this therapy in their practice on how to get started with using the combination therapy, who would be an appropriate candidate to use it for?
Yes, and I think that what I'm going to tell you, it comes from the European Thyroid Association guidelines from 2012. Okay, so this has been around for a while. It's not my invention. This is something that people develop in Europe, and I think that's a great way of starting it. And I recommend fellows to read the 2012 European Thyroid Association guidelines. So the principle is a patient is being treated with levothyroxine and develops residual symptoms, either cognitive symptoms or metabolic symptoms, and the patient doesn't feel well, quality of life is impaired. The first thing you do is, does this patient have hypothyroidism? Because it's common today, the threshold for prescribing levothyroxine is so low that the patient comes with symptoms and the TSH borderline, we are going to put that patient on levothyroxine. So my first reflex reaction is, we need to document that this patient has at some point an elevated TSH. And if the patient doesn't have a record, I would stop, and my clinic stopped many patients from taking levothyroxine, waited a few weeks until TSH went up. If the TSH didn't go up, I would just say, you know what? You're in luck. You don't have hypothyroidism, so you don't have to worry about this anymore. The second thing we have to do is, once we are sure that the patient has hypothyroidism and is still symptomatic, are there other chronic conditions that could cause the symptoms? Because the symptoms, are very non-specific. There's nothing pathognomonic about residual symptoms of hypothyroidism. I wish we had, but we don't. The symptoms are, my memory doesn't work, I feel tired all the time, my skin is dry. These symptoms are everywhere these days. So as it turns out, in my experience, the number one confusing factor, it's menopausal syndrome. The symptoms are very similar, so we have to make sure, if it's a woman, and most patients with hypothyroidism are women, are we getting close to the menopause? Are we dealing with this? Is estrogen replacement therapy an option for this lady? Should we consult a colleague? I think that and in addition to that, anemia, iron deficiency, other autoimmune disease, diabetes, because Hashimoto's is an autoimmune disease, it's more likely you're going to have a second autoimmune disease complicating the situation. So we need to look for other reasons. And if we cannot find another reason, it's basically an exclusion situation here. You exclude everything that you know. Use your common sense. You're a doctor. Just look at the patient. What are you investigating here? If you can't find anything, you say, okay, maybe in this patient then levothyroxine failed. It's worked, resolved the overt hypothyroidism, but we do have some residual symptoms. In that case, what we would do, and colleagues do, is we will try combination therapy. It's a trial. I mean, it's not for sure that it's going to work, but it's the only thing we have today that has been proven to work for many patients. The experience varies, but maybe 50, 60% of the patients will respond positively to combination therapy. Which combination therapy? I like synthetic because I want to control the amounts of T4 and T3 I'm giving, but I have to tell you, patients love desiccated thyroid extract. I don't have that great of an experience with that, but I think we right now the guidelines are completely against it. But I think we really need to think hard on this, because the reality is almost 2 million patients are taking it, 1.5, and we need to understand what this is doing. Now, if we decide we go to the combination therapy, we have to explain to the patient what we're doing. We need to set up expectations. We need to explain that this is a trial, and it might work, it might not work. And after we have all the bases covered, We start by doing what? We reduce the amount of levothyroxine we're giving. Many physicians think that combination therapy is just adding the liothyronine to whatever dose of levothyroxine you're taking. No, that's not right. You have to create room for introduction of liothyronine. You reduce the levothyroxine by a few micrograms, 20, and this paper by the European Thyroid Association gives you a nice formula to calculate by how much you're going to reduce levothyroxine and how much you're going to give of liothyronine. But we're talking about 5 micrograms. We're talking about 7.5 micrograms twice a day or even once a day. I had patients in my office taking 500 micrograms of liothyronine, 600. I mean, this is just nuts. This is not combination therapy by any means. You're introducing a little bit of liothyronine. And you monitor the TSH. The TSH need to be normal. And I'm going to tell you that this is a huge point of contention with the patients. Why? The patients say TSH is not important. We can suppress the TSH. That's not a big deal. You know, they write on my Facebook, Dr. Bianco doesn't know what he's talking about. TSH doesn't do anything. TSH stimulates the thyroid. There's no, so we need to explain to the patient why we're keeping the TSH normal. Now, of course, we know that there's something called central hypothyroidism, secondary. So the patients, you know, a lot of patients think they do have secondary or central hypothyroidism, and you cannot trust TSH. Yeah, that's true. Many of them have, but it's so small the number from a populational point of view. You know, we should think about that, but you know, this is not the rule. This is the exception. So create the room for liothyronine and monitor the TSH. And monitor side effects. Monitor, you know, check for palpitations. You want to adjust the dose of the ratio of T4 and T3 until you have a normal TSH and a patient with less symptoms or with no symptoms, and you're adjusting the dose.
Okay, thank you. I actually just wanted to summarize it a little bit. So 1, confirm the patient has hypothyroidism. Number 2, rule out any other causes, including menopause, especially for women, other autoimmune conditions, anemia, or anything else that might be contributing to the patient's symptoms, since a lot of these symptoms are non-specific, such as fatigue, hair loss, cold intolerance. And then, assuming those are met, start on a combination therapy, preferably synthetic with T4 levothyroxine and T3 liothyronine. And when you do start it, start by managing the patient expectations. So a lot of counseling up front, and then reduce the dose of levothyroxine, and then add the T3 slowly until we get a normal TSH and a patient with a much better symptoms.
Right. The only thing I would note is that it's not preferably with synthetic. It's my personal preference. However, the fact that we have 3 times more patients taking natural thyroid extract as opposed to synthetic, you know, tells me something that we don't understand. Remember, co-payments for levothyroxine and liothyronine, they have to pay 2 co-payments. It's 2 pills. The other one is 1 copayment, 1 tablet. So there are practical issues. My bias is I respect what the patient wants in terms of, I heard my neighbor is on desiccated thyroid extract. That's fine. I'm not going to say, no, don't do that. You kind of have to go synthetic. I did this many years of my life. Every patient that came into my office on combination therapy, I said, forget about it. I'm going to put you on levothyroxine. No, we evolved from there. So I think we need to hear what the patients are telling us. And if they do feel better on desiccated thyroid extract, for me, it's fine, as long as the TSH is normal.
Thank you. So knowing this information, how do you think the practice in general of treatment of hypothyroidism is going to change? Like, is there anything new in the pipeline to come out for medications, or changing in training, new guidelines for the American Thyroid Association? Where are we headed in the future?
The guidelines need to be open-minded and recognize reality here. and recognize that science has evolved. And I think that for the academic physicians that write the guidelines, what do we need to focus? Number one, there were studies showing that the thyroid system is hardwired to preserve serum T3 levels. What does that mean? It means that if you have iron deficiency, T4 will go down, TSH will go up, but guess what? T3 levels are normal. We created a series of mice that were genetically modified to disrupt the feedback mechanism between the pituitary gland and the thyroid. In multiple mouse models, every time we made one, the TSH and T4, they were everywhere, but serum T3 was normal. So the directive for the hypothalamus is to keep T3 within the normal range. I think that's a key important piece of information, because we know, again, based on recent papers and old papers and recent papers, when we treat someone with levothyroxine, we always have a relative deficiency of T3. You have a relative excess of T4, 10, 15% higher, and T3 is 10, 15% lower. So the hypothalamus wants to keep T3 normal at all means. And when we treat our patients, we don't even measure T3 levels. So I think this is a situation that the guidelines need to recognize and say, well, maybe we're not looking at the right thing. Looking at TSH is good. Looking at free T4 is wonderful, but we also need to look at T3. So that's the number one story. We need to include that because it's important. Number two, the guidelines need to acknowledge the fact that there is something called patients with normal TSH and residual symptoms of hypothyroidism. I think we were so much focused on, oh, there were clinical trials, the clinical trials were inconclusive. Well, I mean, the clinical trials is part of the solution. But what is the problem? The problem is that we will find patients when we treat many patients that have normal TSH and they don't feel well only on levothyroxine. And I think that that's the acknowledgement that the patients are waiting, I am waiting to hear from the American Thyroid Association to recognize that the effectiveness of levothyroxine is not 100%. And guess what? There were no clinical trials to say that it was. We took it for granted. We took so much for granted in this area. We need to correct that. Now, there is a concern with combination therapy, which is the peaks of T3. Even if you're talking about 5 micrograms, there's a concern. I think it's a valid concern. I don't think we should ignore that. Even though today there are large studies. In the UK, there was a study in which about 400 patients taking combination therapy were followed for 17 years. And they looked at cardiovascular events, mortality, and it was not different than patients taking levothyroxine. In Sweden, 11,000 patients were followed that were taking T3. And again, mortality was not affected. Recently, I think we need to point out that there was a study in Korea in which they looked at 1,500 patients taking combination therapy, and there they found increased occurrence of heart failure and stroke. But wait a minute, they don't tell us how much they were giving. They don't tell us what the TSH, T3, or T4 were. So for all we know, those patients could be thyrotoxic. I don't know. I mean, I think that we need to stop the fear without evidence. So there is no evidence that combination therapy does anything bad for you when TSH is normal. And to prove that it does something bad, we need to have a real trial showing this is the data, this is the excess of T3, the TSH is doing this, whatever. We need to put the fear in the right place. Now, because of that, the pharmaceutical industry jumped in. And there are at least 3 different efforts, independent efforts, to produce slow release T3 formulations, which makes a lot of sense, right? I mean, if the peaks of T3 are a problem, we're concerned about that, just create a slow release T3. And that's currently going on right now. In Europe, there are two efforts, and in the US, there's one effort. And I suspect that within a few years, we're going to have that in the market.
Right, that's actually really exciting that that's up and
Yes.
coming really soon. And hopefully it'll be affordable for our patients as well.
I think so, yes.
You had mentioned that our previous guidelines had said that a lot of clinical trials that were comparing combination therapy versus standalone levothyroxine were inconclusive. Why do you think that was, we didn't show a significant benefit, especially for that population that it really seems to help?
Great question. So there were about 20 randomized clinical trials that compared levothyroxine with synthetic combination therapy. And at the end of the trials, when they looked at depression, they looked at cognition, they looked at the different parameters, there was no superiority. Combination therapy was not better than levothyroxine. Levothyroxine was not better than combination therapy. And I think that puts to rest the idea of combination therapy for a long time. And in fact, those trials were well done. I mean, I don't think we can criticize them. But there was one thing interesting. They concluded that patients preferred combination therapy. So there were two meta-analyses published recently saying that preference was with combination therapy. Now, some of our colleagues say, well, I don't think preference is important. I think we need to have real measurements, like a questionnaire, something validated. And my point of view is, wait a minute, preference is not important. I mean, if you ask someone, what do you prefer? I have these two treatments that are basically the same. If you prefer one, why am I going to force you to take the one that you don't prefer? So let's respect the patients, because if there's no reason for why not to prescribe combination therapy, and the patient prefers combination therapy, let's do the right thing. That's the common sense. So I think that that's an important summary of these trials. No side effects, no negative things associated with combination therapy. They were just the same. And preference was with combination therapy. But the voice of the patients and the data that has been generated is overwhelming, and say, well, wait a minute, but those trials, there's got to be something wrong with those trials, because how come in my office, I see these patients that love combination therapy that they can't, and how come that's not reflected in the trials? So a few years ago here in Chicago, there was a joint meeting of the American, European, and British Thyroid Association. The experts from the three societies got together, and we concluded that, what's maybe wrong with those trials is that they did not focus on the patients that are symptomatic. They focused on all patients. Yeah, when they recruited patients with hypothyroidism. It didn't have to be patients with residual symptoms. So if I tell you that 15% of the patients have residual symptoms, and I start a trial and I recruit 100 patients, but only 15 patients are going to be with residual symptoms, and then I'm going to randomize in two groups, that's going to be completely diluted. I will never see the results of that, on that subgroup, because it's not powered to do that. So the recommendation was focus on patients with symptoms. Now, future trials should recruit preferably or a substantial number of patients that are symptomatic, even though their TSH is normal. And there was a trial that was published a couple of years ago that I was fortunate to be part of. The trial was from Dr. Shakir and collaborators at the Walter Reed Medical Center in Bethesda, in which they enrolled 85 patients. And there was a crossover, 3 arms. And when you analyze the data, comparing levothyroxine, desiccated thyroid extract, and synthetic combination. So when you look at all patients, it was exactly the 20 trials from the past. There were no differences. But when you ask yourself, wait a minute, let's focus on the patients that did not do well on levothyroxine. Those are the patients that respond positively to combination therapy. And they responded similarly either synthetic T4 and T3 or desiccated thyroid extract. It was no difference, but they responded well. So the idea from this trial was that if you're good on levothyroxine, you're probably not going to be even better on combination therapy. Now, if you don't do well on levothyroxine, there is a good chance that you're going to respond positively to combination therapy. And I think that trial fits all, it's a randomized, double-blinded, crossover trial, and we need more of these trials. But each trial costs millions of dollars. So we need funding for these trials. I mean, it's not trivial to set up a trial that it's powered. There's like a few hundred patients to test these things. It's costs a lot of money.
So designing trials is an important part, but you'd also mentioned that, the patients prefer one treatment over another. Do you think we have a lot of metrics, we're measuring a lot of subjective things, but are we measuring the correct subjective things? Because obviously they do have a preference, but why is it that they have a preference? We're not just catching why they're preferring. We're assuming that we think that these are the reasons that you might choose it.
You're absolutely right. We are asking the wrong questions. I know maybe I'm exaggerating, but the questions, there's a disconnect between our set of clinical outcomes and the patient's set of clinical outcomes. The patient wants something that they prefer, that they like, they feel better. Why? They don't care. You think they care if it's X, Y, or Z? We don't have to explain.
Fix the problem.
Right. What we should do is we're not going to harm our patients, right? So we want to make sure that we're doing something that in the long run, we're not harming anyone. And guess what? There's a lot of data supporting that we're not harming anyone. And there's not a single piece of evidence that we are harming. So the fear that when I started on this thing, I'm telling you, I was afraid of prescribing liothyronine. Okay, because I was told, oh my goodness, we can't do that because we're going to have an atrial fibrillation, osteoporosis, all these things. But where's the data to support that? We just don't have that. That doesn't exist. I think that's important. I think the guidelines need to recognize that.
Along those topics, you had mentioned, that desiccated thyroid hormone and then the combination T4 and T3 in Hashimoto's patients who actually have their thyroid gland, and presumably some of it is working, versus thyroid cancer patients who have had a thyroidectomy and it's removed. Do you think one group would benefit more from these kind of treatments versus another, or they'd kind of be equal?
No, the fact that when you do have some residual thyroid activity, studies have shown that the T3 levels are not that low. Number one, the relative deficiency of T3 is not that low, and patients feel better. So, and that is phenomenal because that has helped change practice. I remember the time when the patient had a thyroid nodule. What are we going to do? Total thyroidectomy or the partial? Just do total, or that was not part of the equation, right? Today, no, the equation is I want to hold on to as much thyroid as I can because I know this is going to be important for my clinical outcome, my quality of life later. So having residual functional thyroid tissue I think is really important. There's papers showing that that's the case.
Thank you. Is there anything else you'd like to share with us today?
No, I'm just very grateful for the opportunity. I think this is a fascinating area that I knew almost nothing about. I was a rat lab. I was really focused on understanding all the detailed molecular mechanisms of these enzymes, fascinating enzymes, the deadenases. And little did I know that they are so important in the treatment of hypothyroidism. We were, in a way, taking for granted that these enzymes that I love dear to my heart, they could do such a phenomenal job that they could produce normal amounts of T3 if we just gave levothyroxine. That's not true. They don't. And it's extremely difficult to normalize TSH levels and T3 levels in the same patient without having a huge excess of T4 in the circulation, just because it does make sense. If the deiodinases by themselves could produce normal T3 levels, why does the thyroid produce T3? And where would the thyroid that comes from the T3 go? Because then you're going to have, if the deiodinases just produce 100% of the T3, the thyroidal T3 is now is in excess of, where would that go? So there is, the deiodinases cannot compensate for that. And I think the understanding of these enzymes, at least for me, allow me to see what was wrong with what we were doing. We were just not, I want to be respectful, because I think that for a number of years, I did not think that was a big problem as well. But I think that not understanding the deiodinase well led us to the situation we are today. It's critically important to realize that there's a T3 deficiency in these patients.
Thank you. And thank you for joining me today, again, for sharing your thoughts on this really important topic. So many people today have hypothyroidism, and it's really important that we treat everyone and not just a certain population of them.
Right.
So we really do need to update our practice and how we treat patients. So thank you again for sharing your thoughts on this information.
Thank you very much for having me. It's been a pleasure.